Inflammatory splenic lesions. Sarcoidosis. Sarcoidosis is a systemic disease of unknown etiology characterized histologically by multiple nodules composed of noncasseating granulomas. When sarcoidosis involves the spleen, splenomegaly is the most common presenting finding, often associated with hepatomegaly and lymphadenopathy. Less commonly, sarcoidosis may involve the spleen in a multinodular pattern with numerous hypotenuating 1 to 3 cm lesions demonstrating essentially no enhancement. These nodules are formed by coalescent sarcoid granulomas and have low signal on all MRI sequences. Sarcoid nodules are most conspicuous on T2 weighted images and early phase post-contrast T1 weighted images. On the post-contrast images, the non-enhancing nodules will stand out against the avidly enhancing splenic parenchyma. Imaging appearance is generally indistinguishable from splenic lymphoma. Inflammatory pseudotumor. Splenic inflammatory pseudotumor is a rare focal collection of immune cells and associated inflammatory exudate of unclear etiology. Patients often have constitutional symptoms including fever and malaise. Inflammatory pseudotumor has a variable and nonspecific imaging appearance, but a typical presentation is of a well-circumscribed, heterogeneously enhancing mass. Splenic infection. Pyogenic abscess. Axial and coronal contrast enhanced CT of the abdomen demonstrates a heterogeneous gas-containing fluid collection arrows within the medial spleen with irregular wall thickening and surrounding parasplenic stranding. This was a case of Staph aureus pyogenic splenic abscess that was subsequently drained percutaneously. Splenic bacterial abscesses are uncommon and usually seen in immunocompromised patients. A solitary abscess is much more likely to be bacterial. In contrast, multifocal small abscesses are more likely to be fungal. On CT, a bacterial abscess usually has an irregular, enhancing wall. Gas is not usually seen but is highly specific for a bacterial abscess when present. A characteristic ultrasound finding is the wheel within a wheel or bull's-eye appearance, which describes concentric hyperechoic and hypoechoic rings surrounding the abscess. Treatment is CTOR ultrasound-guided percutaneous drainage in addition to antibiotics. Fungal abscess. Splenic fungal abscesses are typically multiple and small, usually less than 1 cm in size. Almost all patients with splenic fungal abscesses are immunocompromised. The most common causative agents include Candida, Aspergillus, and Cryptococcus, all of which have a common appearance of multiple tiny hypotenuating foci on cord. Splenic pneumocystis jirovecii, formerly known as pneumocystis carinii, infection is rare, almost always seen in advanced AIDS, and has a classic appearance of multiple calcified splenic lesions. Echinococcal cyst. Splenic involvement of Echinococcus granulosus infection is unusual, seen in only 1–3% of echinococcal infections, and is almost always associated with infection of other organs as well. An echinococcal cyst is a true cyst with a cellular lining. As with echinococcal abscesses elsewhere, characteristic imaging findings are a cystic lesion with internal undulating membrane and daughter cysts. Malignant splenic lesions. Splenic lymphoma. Splenic lymphoma is the most common splenic malignancy. Primary splenic lymphoma is rare, accounting for less than 1% of all cases of lymphoma, and usually presents as a solitary hypovascular mass. In contrast to splenic hematoma or metastatic disease, primary splenic lymphoma may extend beyond the splenic capsule and involve adjacent organs. Secondary splenic involvement of systemic lymphoma is much more common. 4 imaging presentations have been described, depending on the size of the lymphomatous masses. Miliary masses, in which discrete tiny masses may be difficult to see. Multiple small to moderate-sized masses. 1 large mass. Splenomegaly without discrete mass. Conspicuity is highest on post-contrast T1 weighted images, where the involved portion of the spleen tends to be hypoenhancing. On ultrasound, lymphoma may appear cystic, but color Doppler shows internal flow. Splenic metastasis. Splenic metastasis from lung cancer. Contrast-enhanced axial CT shows a hypotenuating, irregular mass in the inferior anterior aspect of the spleen, arrows demonstrating wispy, heterogeneous enhancement. Case courtesy Cheryl Sato, MD, Brigham and Women's Hospital. Splenic metastasis continued. Splenic metastasis may be solitary or multiple, cystic or solid. However, metastasis to the spleen are rare, occurring in 2–9% of cancer patients. Most patients with splenic metastasis already have confirmed widespread disease. Isolated splenic metastasis are seen in only 5% of patients with metastatic involvement of the spleen. Theories for the low rate of splenic metastasis include the antineoplastic properties of lymphoid-rich splenic tissue and lack of afferent lymphatics available to bring tumor cells into the spleen. The most common primary tumors known to metastasize to the spleen include breast, lung, ovarian, and melanoma. Ovarian cancer and melanoma typically cause cystic metastasis. Calcification is rare unless the primary is a mucinous adenocarcinoma. Angiosarcoma. Angiosarcoma is a rare, extremely aggressive malignancy, with a 20% 6-month survival. Unlike hepatic angiosarcoma, the associations with thorotrast, vinyl chloride, and arsenic have not been well established. Angiosarcoma usually presents as a large, heterogeneous mass that may completely replace the normal spleen. Enhancement is variable and heterogeneous. Miscellaneous splenic lesions. Splenic infarct. Splenic infarcts are most commonly due to emboli in older patients and thrombosis in younger patients with hematologic disease. Splenic infarct classically manifests as a wedge-shaped peripheral region of non-enhancement, but a more heterogeneous, mass-like appearance can also be seen. On MR, the affected regions may be T1 hyperintense if acute and hemorrhagic, while chronic infarcts are T1 hypointense and T2 hyperintense. Lack of enhancement of the entire spleen should raise the concern for complete infarction, possibly due to a wandering spleen with torsion. Axial contrast enhanced CT shows a posterior peripheral wedge-shaped region of splenic non-enhancement arrows consistent with infarct. Case courtesy Cheryl Sado, MD, Brigham and Women's Hospital. Gamma-Gandhi bodies. Gamma-Gandhi bodies are multiple tiny foci of hemosiderin deposition and are a sequela of portal hypertension. Other signs of portal hypertension and cirrhosis are usually apparent on imaging, such as splenomegaly, varices, recanalized umbilical vein, ascites, and a nodular liver contour. The hemosiderin deposits demonstrate low signal on all sequences. On an and out-of-phase gradient echo sequences, the longer T of the in-phase images demonstrates blooming, relatively decreased signal on in-phase images due to longer dephasing time and exaggeration of T2 asterisk effect. Gamma-Gandhi bodies continued. Axial and out-of-phase gradient echo MRI shows numerous low-signal foci in the spleen which demonstrate blooming on in-phase imaging, right image compared to out-of-phase imaging, left image representing Gamma-Gandhi bodies. Note cirrhotic morphology of the liver, nodular contour, widened fissures, multiple regenerative nodules. Gaucher disease. Gaucher disease is an autosomal recessive deficiency of glucocerebrosidase, leading to accumulation of glucocerebrosides in the reticuloendothelial system. Splenic manifestations of Gaucher disease include splenomegaly, almost always, and multiple splenic nodules, seen in 1/3 of Gaucher patients. Associated bony findings seen in Gaucher disease include the characteristic Erlenmeyer-Flask deformity of the distal femurs, femoral head avascular necrosis, and H-shaped vertebral bodies from endplate avascular necrosis. Splenic trauma. Overview of splenic trauma. The spleen is the most commonly injured abdominal organ in blunt trauma. Splenectomy dramatically increases the risk of subsequent sepsis, which has driven the trend towards splenic preservation and conservative management of splenic trauma. The spleen must be evaluated for injury in the portal venous phase, as physiologic heterogeneous enhancement in the arterial phase can both mask and mimic injury. A splenic hematoma is a focal collection of blood hypoattenuating relative to enhanced spleen and hyperattenuating relative to unenhanced spleen, usually subcapsular in location. Less commonly, a hematoma may be intraparenchymal, where it is irregular in shape. A splenic laceration can only be well seen on a contrast-enhanced study, where it appears as a linear or branching area of decreased attenuation. Active contrast extravasation due to vessel injury appears as an area of increased attenuation, initially iso-enhancing to the arterial blood pool, which continues to increase in size or attenuation on delayed scanning due to pooling of extravasated blood. In contrast to active extravasation, pseudo-aneurysm and arteriovenous AV fistula are contained vascular injuries that also initially appear as a focal area of increased attenuation, but do not increase in size on delayed scanning. A pseudo-aneurysm is caused by injury to the intima and media of the arterial wall and is essentially a rupture contained only by the adventitia. There is a high chance of rupture without treatment. A traumatic AV fistula is indistinguishable from pseudo-aneurysm by CT and is due to injury of an artery in the adjacent vein. Splenic arteriography is the only way to differentiate pseudo-aneurysm from arteriovenous fistula. American Association for the Surgery of Trauma Organ Injury Scale for Spleen. The 2018 revision of the AAST spleen injury scale takes into consideration the extent of injury seen on CT imaging, at operation, or on pathologic specimen. The highest grade assessment represents the final grade assigned. The revision incorporates vascular injury seen on CT including active bleeding, pseudo-aneurysm, and AV fistula as defined above. The CT imaging criteria is similar to that used for liver trauma. Grade 1. Subcapsular hematoma less than 10% spleen surface. Tear of splenic capsule or superficial laceration less than 1 cm deep. Grade 2. Subcapsular hematoma 10 to 50% spleen surface. Intraparenchymal hematoma less than 5 cm in size. Laceration 1 to 3 cm deep. Grade 3. Subcapsular hematoma greater than 50% spleen surface. Ruptured subcapsular intraparenchymal hematoma. Laceration greater than 3 cm deep. Grade 4. Any intraparenchymal vascular injury, i.e., pseudo-aneurysm or AV fistula, or contained active bleeding. Laceration involving central splenic vessels resulting in greater than 25% devascularization. Grade 5. Extraparenchymal extension of active bleeding into the peritoneum. Shattered spleen. When multiple injuries are present, advance one grade up to a grade 3. Left image. Coronal contrast enhanced CT demonstrates a large subcapsular hematoma, arrows compressing the spleen, without evidence of active extravasation, in keeping with grade 3 splenic injury. Right image. Axial contrast enhanced CT shows a shattered spleen, grade 5, with surrounding hematoma. AASTSPLENE-NJURYSCALE. Common imaging patterns of splenic disease. Splenic calcification. Granulomatous disease, calcifications may be scattered or diffuse. Infarct, remote. Hematoma. Calcified splenic artery aneurysm. Cystic splenic lesion, on ultrasound. Color Doppler should always be used to exclude a vascular etiology. Epithelial cyst. Splenic artery aneurysm or pseudo-aneurysm. Hematoma. Abscess. Pancreatic pseudocyst. Hypervascular or hyperechoic splenic lesion. Hemangioma can also be hypoechoic. Hamartoma. Lymphangioma. Angiosarcoma. Hypovascular or hypoechoic splenic lesion. Laceration in the setting of trauma. Abscess. Lymphoma. Sarcoidosis. Metastasis. Infarct tends to be peripheral. Extramedullary hematopoiesis. Splenomegaly defined as greater than 14 cm in sagittal plane. Mild to moderate splenomegaly. Portal hypertension most common. Infection. AIDS. Moderate to marked splenomegaly. Leukemia, lymphoma. Infectious mononucleosis. Massive splenomegaly. Myelofibrosis. Esophagus. Anatomy. Pharynx. Nasopharynx. Extends from the base of the skull to the soft palate. Oropharynx. Located behind the mouth and extends from the uvula to the hyoid bone. Hypopharynx. Extends from the hyoid bone to the cricopharyngeus muscle, which is located at the lower end of the cricoid cartilage, usually between C5 to 6. Esophagus. The cricopharyngeus muscle is the upper esophageal sphincter and demarcates the transition between the hypopharynx superiorly and the cervical esophagus. The esophagus extends from the neck to the gastroesophageal junction. The distal esophagus passes through the diaphragmatic hiatus at approximately T10. The three anatomic rings of the distal esophagus are the A muscular, B mucosal, and C diaphragmatic impression rings. Double contrast barium swallow showing normal impressions on the esophagus by the aortic arch (AO), yellow arrows, and left mainstem bronchus, red arrow. Single contrast barium speech and swallow study demonstrates a prominent cricopharyngeus muscle arrow on sagittal view, forming a smooth posterior indentation on the esophagus at level of C5. Imaging the esophagus. Overview of esophageal imaging. The primary imaging modality for evaluating the esophagus is fluoroscopy, which allows for anatomic and function evaluation. A double contrast esophagram utilizes barium and gas-forming crystals to simultaneously distend the esophagus and coat the mucosa with radiopaque contrast. The dynamic nature of the study also allows for evaluation of reflux and motility disorders. A single contrast esophagram may be used when you are evaluating for a post-operative leak, performed with water-soluble contrast rather than barium, or if a patient cannot tolerate the gas-forming crystals. Overview of esophageal imaging, continued. Barium is the contrast agent of choice unless there is concern for an esophageal leak. In that case, water-soluble contrast is preferred. If the patient has a significant aspiration risk, however, high osmolality water-soluble contrast should be avoided due to risk of pneumonitis. If an esophageal malignancy has been diagnosed, PET-CT may be used to stage for locoregional lymph nodes and metastatic disease, and endoscopic ultrasound is utilized for evaluating the depth of the lesion T stage and the presence of local lymph nodes. CT and MRI have a limited role in evaluation of primary esophageal pathology. Esophageal rings and webs. Esophageal web. An esophageal web is a thin anterior infolding indentation, usually occurring in the anterior cervical esophagus, which is often asymptomatic but may be a cause of dysphagia if it significantly narrows the lumen. There is a controversial association with anemia, Plummer-Vinson syndrome, and carcinoma of the upper esophagus. Shotsuki ring. A Shotsuki ring is a focal pathologic narrowing of the B mucosal ring of the distal esophagus less than 13 mm causing intermittent dysphagia. Asymptomatic narrowing of the B ring is referred to as a lower esophageal ring. The key imaging feature is focal, thin, circumferential constriction near the GE junction, almost always associated with a hiatal hernia, best seen in the route-prone position. An upper GI study is more sensitive than endoscopy for diagnosis. On an esophagram or an upper GI study, most symptomatic rings do not allow passage of a 13 mm barium tablet. The differential of circumferential esophageal constriction includes focal stricture, muscular esophageal ring above the GE junction, also known as an A ring. Esophageal cancer associated with irregular mucosal contour and an apple core appearance. Esophageal web, rarely circumferential, usually in cervical esophagus. Shotsuki ring. Double contrast barium swallow in a patient with dysphagia shows a circumferential narrowing, arrows, at the gastroesophageal junction, associated with a small hiatal hernia. Case courtesy Cheryl Sado, MD, Brigham and Women's Hospital. Esophagitis. Reflux peptic esophagitis. Reflux peptic esophagitis is caused by gastroesophageal reflux leading to the exposure of the esophageal mucosa to acidic gastric secretions, which may lead to distal ulcerations and eventual stricture as well as the development of Barrett's esophagus. Peptic esophagitis is most commonly caused by an incompetent lower esophageal sphincter but may also be seen in Zollinger-Ellison syndrome, due to increased acid production. Scleroderma, due to gastroesophageal sphincter fibrosis and resultant incompetence. Fluoroscopic findings of reflux esophagitis are usually seen in the distal esophagus and are best demonstrated on double contrast images. These findings include mucosal granularity, thickened folds. Erosions may be solitary or multiple, typically on posterior wall. Strictures. Thickened esophageal folds in reflux esophagitis. Barrett's esophagus. An important long-term sequela of peptic esophagitis is Barrett's esophagus, which is metaplasia of normal squamous epithelium to gastric-type adenomatous mucosa. Barrett's esophagus is a precursor lesion to esophageal adenocarcinoma. Nearly 10% of patients with reflux esophagitis may have some adenomatous metaplasia. On double contrast fluoroscopy, Barrett's esophagus demonstrates a reticular, web-like mucosal pattern, often with a segmental stricture in the mid-esophagus. Barrett's esophagus is often associated with esophageal stricture, which is abnormally high in location compared to a peptic stricture. Infectious esophagitis. Although radiographic distinction between types of infections has been described, endoscopy and biopsy are typically performed in clinical practice to differentiate. Esophageal candidiasis can present as a spectrum from scattered plaque-like lesions in mild disease to very shaggy-appearing esophagus in severe cases. Herpes esophagitis typically causes small, discrete ulcerations scattered randomly throughout the esophagus. CMV/HIV esophagitis characteristically causes a large, flat, ovoid ulcer. Candida esophagitis. Spot image from double contrast esophagram shows a diffuse, shaggy appearance to the entire visualized esophagus, consistent with severe Candida esophagitis. Case courtesy of Cheryl Sado, MD, Brigham and Women's Hospital. Medication esophagitis. Medication-induced esophagitis occurs secondary to pills being stuck in areas of relative narrowing, classically at level of aortic arch or distal esophagus, resulting in erosions. Crohn's esophagitis. Crohn's esophagitis is very rare and is usually seen in the satiety of severe disease throughout the small bowel and colon. Aphthous ulcers, discrete ulcers surrounded by mounds of edema, may become confluent. Eosinophilic esophagitis. Eosinophilic esophagitis is an idiopathic inflammatory disorder characterized by activation of eosinophils within the wall of the esophagus leading to strictures, webs, and spasm. This often presents with food impaction. The appearance is of concentric mucosal ring-like strictures. Chemotherapy-associated mucositis. Certain chemotherapy agents can cause oropharyngeal mucositis, which may extend to the esophagus. This can lead to severe odynodysphagia, subsequent dehydration and malnutrition. While the condition is usually self-limited, it can last weeks to months. Esophageal strictures. Peptic stricture. As previously discussed, a peptic stricture is secondary to chronic reflux. Peptic strictures are located distally, usually just above GE junction, and may be focal or involve a longer segment of the esophagus. Fibrosis can cause esophageal shortening, leading to a hiatal hernia as the stomach is pulled into the thorax. Barrett's esophagus stricture. A Barrett's stricture typically occurs in the mid-esophagus above the metaplastic adenomatous transition because adenomatous tissue is acid-resistant and therefore unaffected by gastric secretions. Malignant stricture, due to esophageal carcinoma. Barium swallow, left image, demonstrates abrupt narrowing, arrows, of the distal esophagus with subtle mucosal irregularity. Sagittal CT, right image, shows mass-like soft tissue thickening in the same region. The key imaging finding is irregular narrowing with shouldered margins, apple core appearance. Caustic stricture, nasogastric tube stricture. Both caustic strictures and strictures secondary to nasogastric tube placement are typically long, smooth, and narrow. Strictures develop 1 to 3 months after the causative event. Caustic strictures are associated with an increased risk of cancer with a long lag time of up to 20 years after the initial insult. Caustic strictures are usually longer than peptic strictures. Radiation stricture. Like caustic strictures, radiation strictures are long, smooth and narrow and occur in the radiation field. It generally requires more than 50 grays of radiation to cause an esophageal stricture. Acute radiation esophagitis occurs 1 to 4 weeks after radiation therapy. Radiation strictures develop later, about 4 to 8 months after radiation. Extrinsic compression from mediastinal adenopathy. Cross-sectional imaging with CT or MRI is best to evaluate if extrinsic compression is suspected. Evaluation of esophageal masses. Masses arising from the mucosa, submucosa, and extrinsic to the esophagus produce characteristic effects on the esophagus, which are usually able to be seen on imaging. Lesions arising from the mucosa create an acute angle relative to the adjacent wall, whereas the submucosal lesions create an obtuse angle as demonstrated below. Mucosal submucosal extrinsic compression. Benign esophageal masses. Mesenchymal tumor. Benign mesenchymal tumors are the most common submucosal esophageal tumors and include leiomyoma, lipoma, hemangioma, and others. Leiomyomas are the most common. On a barium swallow, a mesenchymal tumor typically appears as smooth, round, submucosal filling defect. Compared to esophageal leiomyomas, esophageal gastrointestinal stromal tumors, GIST, are rare and may be benign or malignant. In contrast, GISTs are more common than leiomyomas in the stomach. Adenoma. An esophageal adenoma is a benign mucosal lesion with malignant potential, usually arising within Barrett's esophagus and appears as a filling defect, most less than 1.5 cm in size with acute margins on esophagram. Fibrovascular polyp. A fibrovascular polyp is a pedunculated mass composed of mesenchymal elements with a significant fatty component. In contrast to an esophageal adenoma, there is no malignant potential. Fibrovascular polyps usually occur in the cervical esophagus where they gradually elongate. Clinical presentation can be dramatic with regurgitation of a fleshy mass. CT is usually diagnostic, demonstrating an intralesional fatty component. Inflammatory polyp. An inflammatory polyp is a non-neoplastic, enlarged gastric mucosal fold that protrudes up into the lower esophagus. Inflammatory polyps are almost always associated with reflux and must be contiguous with a gastric fold. Varices. Barium esophagram, left image, demonstrates oblique extrinsic impression along the left anterolateral distal esophagus, red arrow. Coronal contrast enhanced CT, right image, demonstrates extensive bulky esophageal varices. Note this patient also has cirrhotic liver with ascites, presumably the etiology of portal hypertension. Varices can usually be distinguished from a solid mass on fluoroscopy since varices change in size and shape with peristalsis and Valsalva maneuver. However, thrombosed varices may mimic a tumor. Uphill varices are most common, due to portal hypertension, affecting the distal esophagus. Blood flows, uphill, from the portal vein left gastric, coronary vein, periesophageal venous plexus azygos, hemiazygos collaterals SVC. Downhill varices are less common, due to superior vena cava obstruction, usually affecting the proximal esophagus. Enlarged collateral vessels include the supreme intercostal veins, drain the first intercostal space, bronchial veins, and inferior thyroidal veins. Foregut duplication cysts. Esophageal duplication cysts are lined with squamous epithelium, have a smooth muscle wall, and are usually in the posterior mediastinum. They may be either extrinsic to the esophagus or submucosal, the latter is impossible to differentiate from a leiomyoma by esophagram. Bronchogenic cysts are lined by respiratory epithelium and are usually in the middle mediastinum. They are generally indistinguishable from an esophageal duplication cyst on esophagram and court. Neurenteric cysts are associated with vertebral body anomalies. Esophageal foreign body. A radiopaque esophageal foreign body is best visualized with a lateral radiograph or court. Bony foreign objects usually get stuck in the cervical esophagus. Meat impaction usually occurs at the gastroesophageal junction. There is a risk of esophageal perforation from transmural ischemia if the food bolus is impacted for greater than 24 hours. Most cases of food bolus impaction are treated with endoscopic removal of the impacted food. Malignant esophageal masses. Esophageal carcinoma. Esophageal carcinoma. Oblique fluoroscopic spot image from a barium swallow, left image shows an irregular stricture, yellow arrows with proximal dilation of the esophagus. Two linear ulcerations, red arrows, project into the mural mass. Contrast-enhanced axial CT, right image, shows irregular thickening of the esophagus, arrows. Case courtesy of Cheryl Sato, MD, Brigham and Women's Hospital. Esophageal carcinoma has a broad range of appearances. Early esophageal cancer may be apparent on barium swallow as a plaque-like lesion, polypoid lesion, or focal irregularity of the esophageal wall. A classic appearance of advanced esophageal carcinoma is a mass causing a stricture with a shouldered edge and irregular contour, apple core appearance. The uncommon varicoid appearance can be confused with varices, but the tumor does not change shape with peristaltic waves as varices typically do. Esophageal carcinoma may be squamous cell carcinoma, SCC, or adenocarcinoma. These cannot be reliably differentiated by imaging, although SCC tends to involve the upper or mid-esophagus and adenocarcinoma typically involves the distal esophagus and may extend into the stomach. SCC is most commonly due to smoking and alcohol. Less common risk factors include celiac disease, Plummer-Vinson syndrome, achalasia, and human papillomavirus more commonly causes laryngeal SCC. Adenocarcinoma usually arises from Barrett's esophagus and is due to chronic reflux. The incidence has been rising in recent years. Metastasis. Direct invasion of the esophagus is most commonly from gastric, lung, or breast primaries. Hematogenous spread is very rare. Most often, mediastinal lymph node metastasis will be prominent. The mid-esophagus is most commonly affected due to its proximity to mediastinal lymph nodes. Lymphoma. Esophageal lymphoma is often indistinguishable from primary esophageal cancer. Malignant gastrointestinal stromal tumors. Malignant GIST is a submucosal mesenchymal tumor which tends to be bulkier and more irregular than the benign variant. Esophageal motility disorders. Contraction waves. A primary contraction wave is a normal, physiologic wave initiated by a swallow. A secondary contraction wave is a normal, physiologic wave initiated by a bolus in the esophagus. A tertiary wave is a non-propulsive contraction that does not result in esophageal clearing. Tertiary contractions are seen more commonly in the elderly. In the left image, tertiary contractions result in moderate delay of contrast passage during the primary swallow, with subsequent reflux of contrast, right image. Achalasia. Achalasia. Fluoroscopic spot image from an upper GI series, left image, shows a markedly dilated esophagus terminating in a bird's beak, yellow arrow, at the GE junction, due to failure of the distal esophageal sphincter to relax. Axial non-contrast CT confirms the markedly dilated, debris-filled esophagus, red arrows. Achalasia is a motility disorder resulting from the inability of the distal esophagus to relax because of abnormal myenteric ganglia in the Auerbach plexus. Vigorous achalasia is a less severe form of achalasia consisting of repetitive non-propulsive contractions.